AAKOMA has three key foci: raising consciousness, empowering people, and changing the system of mental health.
50% of youth of color report moderate or severe anxiety or depression.
For me, part of it is we've never asked diverse young people the question. But how do you help those young people if you don't know what their needs are? Young people don't have access.
Part of it is also how we're asking the question. Many people think when they think depression, they think sadness. No, it's just a teenager being a teenager. Because treatment is not a one-size-fits-all model.
Welcome to Khan Klinics, your dedicated space for exploring the vital connections that shape your well-being. Here we dive into everything from achieving peak physical fitness by mastering sustainable weight management to optimizing your diet for a vibrant life. We're passionate about uncovering the power interplay between your mental and physical health, offering you insightful strategies to nurture both. Join us as we unlock the secrets to embark on your self-confidence and your inspiration by interviewing top-rated personalities, not from only the US, but around the world. At Khan Klinics, our commitment is to bring you evidence-based information that inspires you to confidently control your health journey and live your life to the absolute fullness. I'm your host, Amir Khan. Let's get ready to unlock the true potential of being a human with the most amazing people around us. We're living in a world where talent, excellence, and activism don't shield our youth from emotional distress. While young leaders rise and create voices, grow louder, many still wrestle silently with anxiety, trauma, and disconnection, especially those from marginalized communities. A 2025 open access path analysis study involving 362 African American youth explored how everyday racial discrimination leads to depression and suicidal ideation, and how social connectedness can buffer these effects. A 2023 PubMed examined study on racial and gender gaps in mental health diagnosis among adolescents and pediatric primary care found African American female had 48% higher odds of receiving a suicide-related diagnosis without proper recognition of depression or anxiety, highlighting the systemic underdiagnosis. A similar 2023 meta-analysis confirmed what many parents and educators already suspect: problematic social media use and upward social comparisons are driving increased rates of depression, anxiety, self-harm, and suicidal thoughts among teens. These aren't just statistics, they're real young lives burdened by marginalized cultural invisibility and systemic trauma. Today, we're joined by two experts who are turning research into action and pain into progress. Together, they're reshaping how we care for youth, and today, they're sharing how we all can play a part. Welcome to another enlightening episode of Khan Klinics. I'm your host, Dr. Khan, and today we're honored to be joined by not one, but two extraordinary voices in youth mental health. They're a leading movement, one that blends science, advocacy, and compassion to change lives. Dr. Alfiee Noble and Camelia Harb. Dr. Alfiee is a clinical psychologist, a researcher, a youth mental health advocate. She founded the nonprofit AAKOMA, AAKOMA project in 1999, pioneering cultural responsive mental health outreach for youth of color. She's also the host of the mental health podcast, Coached in Color with Dr. Alfiee. Dr. Alfiee is a global mental health leader, recently named a 2024 World Leader by Belinda French Gates, helping lead a 20 million fund to support the health of women and girls. She's a media voice and has been appeared on many shows like the New York Times, the Today Show. She earned her counseling from NYU degree and the University of Wisconsin Medicine and Duke University of School of Medicine. She's an accomplished author and speaker as well. Dr. Alfiee, welcome to the show.
Thank you for having me.
Dr. Camelia Harb is a research and operation analyst at the AAKOMA project, where she applies community-based participatory research to address mental health disparities. She holds a PhD in clinical psychology from the University of Missouri St. Louis and earned a BA and MA in psychology. She co-authored research on faith-based mental health promotion and cultural responsive methodologies in books like Community Mental Health Engagement with Racial Diverse Population. She co-authored with Dr. Alfiee. Dr. Camelia, welcome to the show as well.
Thank you so much for having me.
So let's ask you ladies first. We'll start by the AAKOMA project. What inspired you to found it? We want to tell our audience and what is its core mission we're trying to address here with mental health needs for youth, people of color.
So it's a wonderful question. I appreciate it. And for me, it's twofold. Part of it is I really believe through all my training, I did the very traditional academic medicine route. I was in multiple departments of psychiatry throughout my career, and I did all the alphabet soup, the training grants, the F grants, the T grants, all that stuff, the K award, auto ones. And one of the things that I learned throughout all my training and my years as a psychiatry professor is that innovation and filling in gaps are really what our responsibilities are as academics, whether we're inside the academy or not. And one of the big glaring gaps in our field, in the field of youth mental health, is data that reflects all of the young people who are impacted, which means everybody. So of all races, ethnicities, cultural backgrounds, whether you immigrated to the United States or not, our work is mostly focused on the United States. I want to be honest about that. Wherever your family came from, whatever your family story, you deserve to be reflected in the literature. And there are too many groups who have never been reflected in our literature properly. So we fill a gap at the AAKOMA project. That was part of why I started it. That's part of the impetus for it. Secondly, for me, it was really important to always ensure that other people had access to the kind of compassion, understanding, and empathy, right? That's what we're supposed to do in medicine and in psychiatry and in the field of mental health writ large. Our goal, part of what we're charged with, is to care for people. And how do you care for people if you don't know what people's needs are? And how do you know what their needs are if you don't ask them? And so for me, those were things that happened in my home. We checked in about, not necessarily about mental health. I'm Generation X, so my parents are boomers. They weren't talking about mental health, but we did check in on things like, how's your heart? How you feeling? How was your day? And I had a lot of support in my home. Once I got out of the home, I've said this many times, it didn't always feel like I had support. And I knew I wasn't alone as a young woman of color. And so where I grew up, Virginia Beach, Virginia, I tell everybody there were three primary racial ethnic groups that were very represented. It was Black folks, white folks, and Filipinos. And so for us Filipino and Black kids, there was always this need, especially if we were as honor students and great students, you felt isolated and ostracized. And so my goal was, if I had the support in the home, other kids should have that too. And so my goal was to establish something that would replicate the kind of love and care and cultural groundedness that I had at home. I was proud of being Black. I wanted other kids to have that kind of thing for themselves too. So AAKOMA has three key foci: raising consciousness, empowering people, and changing the system of mental health. That's what we're about, and that's why we were founded.
Excellent. Well, thank you for explaining that, Dr. Alfie. I think that makes that clarifies a lot of things. It's not only data that is out there, but there is very little realization that what impact it actually has. And it's a separate story bringing the awareness, educating people. I think a lot of people get that, and especially when you're dive into looking into the data and working with you, it brings a lot of realization. Example: 50% of youth of color report moderate or severe anxiety or depression. That's a staggering figure. What is it that is preventing this group from A, getting realization, B, getting access to this disorder? It's definitely fixable.
I think there are a couple things, and I'll let Dr. Camelia weigh in too. For me, part of it is we've never asked diverse young people the question, right? We always talk about, you know this from your work, when we cite research, you open citing PubMed and some other journals. We focus on representativeness. That has always been a thorn in my side because when you focus on representativeness, it's too easy to leave people out. So let's think about one group that we added to our research this year that I regret that we didn't do the first time because our study this year is a replication study from 2023. We added Arab slash Middle Eastern North African youth. I can't tell you where I ever saw data on that population when I was in training. So how can you help a young person who comes from that background? And you talk about loads of countries, right? But how do you help those young people if you don't know what their needs are? And if you focus on only representativeness in clinical trials and we're looking at cross-sectional data, when you look at the data that's out there, you wouldn't know what was going on with those kids. Nobody asked these kids what's going on with them. So for me, that's part of the reason we don't know because we don't ask. And that's an easy fix. These kids exist. These kids are out there. You can find them. You can ask them. They will tell you if you ask nicely. So that's always been my thing. You have to ask people. I think the other thing is once you ask enough young people and you get enough information about what their needs are, now you know that there are targets, right? Because that's what you do in medicine. You ask questions to gain insights, then you take the information you've been given, you look at all the training you've received, or you look at how symptoms cluster to form a disorder, then you know what the disorder is, you have a label, you can work towards addressing the disorder. For us, that's really what it's about. So I'll yield to Dr. Camelia, but some of it is young people don't have access, not because the interventions aren't there. They are there, but it's because you have to make that crosswalk from identifying an issue to locating the help to getting the young person into the help. And I think we've, in our field in general, have often failed in many ways. We get some stuff right, but we failed in many ways to make that through line from identifying need to identifying help to connecting the young person and their family and or their community to the help. I don't know if you wanted to add anything, Dr. Camelia.
No, thank you. I agree everything Dr. Alfiee is saying. And I think part of it is also how we're asking the question. So if we're not asking it in a way that is understood or that translates well to these different groups. So a very good example of this could be something like depression. Many people think when they think depression, they think sadness. And the image that comes to mind is someone that can't get out of their bed in the morning. But for some people, depression manifests as irritability, anger, frustration, or this just disconnect, social withdrawal. And we're seeing this a lot more and more with younger people, particularly the social aspect of it, of pulling away, of being isolated, of not engaging with families, engaging with friends. But if we're not changing our frame of mind to think maybe this is depression that's coming out, oh no, it's just a teenager being a teenager or something, like we miss the opportunity to ask them and meet them so they can even understand what's going on for themselves. And when it comes to the access piece, it's also the systems that exist, as Dr. Alfiee was saying, they are out there. Most to many times, they need to be turned just slightly, 10 degrees, 15 degrees, a little bit more for different people to meet them where they're at and also in the language that they understand so that they're structured in a way that takes into account their intersecting identities and the differences that they are bringing to the table. Because treatment is not a one-size-fits-all. model. And that is where a lot of times that gap happens for people of color, for youth of color in particular.
Dr. Harb, thanks for explaining that. I have a follow-up question, and that is there a lack of a cultural understanding on behalf of a lot of people when they try to fit in, like you said, one fit model for everyone? That's not going to apply for people of color, a lot of them, and especially when we look at the data and we apply it to females who are more even vulnerable in that subgroup compared to men. Where is the data? How are we going to get that? And when are we going to analyze it?
The data, so two things. What I love about this question is it gives me an opportunity to be on a soapbox I've been on for years. Dr. Camelia's known me at this point almost a decade. Yeah, it's been almost a decade. And that whole time I've been saying the same thing. We keep funding in our country the same biomedical research. When we talk about innovation, it is incremental. Literally, it might be changing one variable in a protocol where maybe you're delivering care virtually versus in person. That's what we do. What we don't do enough of is find the money, right? In our most of our research is biomedical research. Our innovations are funded by the federal government and or private industry. In those instances, what I think we haven't done enough of is go out and talk to the people who are least likely historically to benefit from the innovations. Who are those people? And if you can go and talk to those people, my thing is a rising tide lifts all boats. If you can reach the people who have been least likely to benefit and you can design interventions to benefit those folks, everybody else is going to be okay because you're designing for the folks who have the least access, who are least likely to have a voice, who are least likely to be included. Everybody else you're going to capture anyway because you already know how to design and capture information for them. So that's a part of it. I think the other part of it is I really feel like we need enough of our academics, whether you're in academia or outside academia. I identify as a liberated academic. I'm still an academic, just not in the traditional academic sense. If there are enough of us out here doing this work, I think we can generate the kind of data that we need to help us better answer the questions that need to be answered to move us forward in terms of treatment of what is going on with our young people. So I'll say it like this. If, for example, I am able to go out and get enough money to go out and talk to enough, as you shared, young girls of different backgrounds to understand what is it that contributes to their depression, and then, which is what we did, and then I can look at all of the standard symptoms of depression, and I can say, okay, for Latinas, these are the 2 or 3 symptoms that are most likely to be present when you talk about depression. These are the 2 or 3 symptoms for Black girls that are most likely to be present when you talk about anxiety. Okay, now I have targets. Now I know interventions. Now I know a cluster of symptoms that I can focus on to develop an intervention or tweak my intervention, right? What's the big one? Everybody loves cognitive behavioral therapy. Well, how do you tweak that to fit the needs of, say, a little Muslim girl whose family immigrated? Maybe you have to incorporate the family in order to support that unit aligned with that family's value system. But you need data to be able to do that. So for me, those are the facets that are really important, and those are the things that we need to do to improve our treatments so that we don't have these disparities between boys and girls or between kids of color and white kids.
Dr. Harb, would you like to add anything to that?
Yeah, I mean, I echo everything that Dr. Alfiee is saying. It's also because this wraps into the work that, I've done over the years with Dr. Alfiee about community-based mental health. It might seem sort of extreme for me to say this way, but there is this divide between community-based approaches and like traditional research approaches. And one of the biggest things is the time that has to go into community-based approaches. So it's not to say that individuals of marginalized backgrounds don't want to be involved in research, or it's not worth it, or it's more difficult, but there is this idea of, as Dr. Alfiee was saying before, representative samples versus equitable samples. It takes time to get an equitable sample, particularly if you are recruiting from samples that are not historically seen in the literature. It doesn't mean that they don't want to be in the literature, but you may have to do a little bit of extra work to get to them. So from like a
Sure.
community-based participatory methodology approach, a lot of that involves getting into the population, learning the population, working with the population alongside them, not from above. So traditional medicine has this idea of like, you know, come in, get what you need and leave, and then you publish and everything's good. From a community-based perspective, it's how can I develop this research with the people I want to research so that the outcome benefits them. So if you're interested in depression for, let's say, Arab girls, I might think from my perspective, well, I want to study depression in Arab girls because I want to figure out what the stats are and how I can better get my numbers up in my treatment center. But maybe for them, their idea is, well, yeah, we want you to study depression too, but for us, it's because it's affecting my family life. It's affecting my school life. So that changes the research question from just depression in Arab girls to depression in Arab girls that directly has impact on their social functioning and their academic functioning. So this is the idea of when we talk about shifting the lens of traditional research a little bit, it's not overhauling the whole system. It's just taking what we have and changing it so that it more appropriately recognizes and appreciates the diversity of people that it's trying to serve. So this is part of like why, like you're saying, where is the research, where it is out there, but a lot of times what's precluding more of it from being out there is the time, the cost, and this, I don't want to just put it all on academia, but like this, you know, stuckness, not a better word is coming to mind, with traditional research methodologies, of that being the gold standard that we are hesitant to drift away from.
What a remarkable journey we've just experienced together. The path to health isn't always straight, but it's always worth the effort. I hope today's conversation inspired you to take the next step in your wellness journey, armed with new knowledge and a fresh perspective. If today's episode left you inspired, share it with people, someone who need to hear this. Give us a thumbs up and your opinion. Keep exploring, keep evolving, and we'll see you in the next episode of Khan Klinics.